Okay, so I talked earlier on about the importance of establishing a standardized kit dump, but I also said that the contents is going to vary between organizations and situations. So this section isn't going to describe each individual item and where to put it, but I do want to provide you with some evidence and some considerations that might influence the decisions you need to make around what is included. And it's worth saying at this point that everything you choose needs to be carefully prepared and checked before you lay it out. So one of the biggest decisions that you're likely to make is whether to use direct or video laryngoscopy. Well, that's if you've got the choice. But thankfully, in 2022, there was a Cochrane review published on exactly this question, and it concluded that video laryngoscopes of all designs reduce the rates of failed intubation, improve glottic views, and result in higher rates of first-pass success. Excellent. So that's that then. Well, not necessarily, because actually, although there were 222 studies included in that review, loads of them were from planned surgical cases, and that might not be representative of our cohort of patients, or certainly our workplaces. So let's look at those two options in just a little bit more detail. So a direct laryngoscope is our traditional choice. It consists of a handle and a blade with a light source. It's been around for years, and therefore the equipment and the associated techniques are going to be very familiar to many people. And the direct laryngoscope does exactly what it says on the tin. It's used to manipulate the tongue and the soft tissues to provide a direct line of sight between the intubator's eye and the glottis. But if the direct laryngoscope is the professor at the front of the classroom, video laryngoscopes are the students with their shirts untucked, whispering at the back and generally being a bit disruptive. Because while you can view them as annoying new technology that has to be tolerated, they are the future. Video laryngoscopes still have a handle and a blade, but near the tip of that blade is a camera with a light source. And within the blade are a set of fiber optics which transmit the image from the camera back to a screen. That's either on top of the handle or remote to the laryngoscope via a cable. But the clever thing about video laryngoscopes is that they acknowledge the technical and sometimes anatomical difficulties of obtaining a direct view of the glottis, and they allow the operator to gain a view of the glottis by looking around the obstructive tissues rather than just relying on their displacement alone. So how do we choose between the professor or the students? Well, alongside that Cochrane review, there's an increasing body of evidence that is pretty hard to ignore, which really supports the use of video laryngoscopy in both emergency departments and pre-hospital care. And the benefits that are described become more pronounced as the airway becomes more difficult and the intubator becomes less experienced. But it's not just improved intubation success. Because video laryngoscopy removes the need for a direct line of sight, that means the forces involved in laryngoscopy are less, and it allows us to obtain a good glottic view even with restricted mouth opening or immobilization of the C-spine. And the video laryngoscopes also magnify the view of the glottis and give us a wider angle of view. Both of those things make it easier to identify the relevant anatomy. But one of the biggest benefits is that your assistant can see what you're seeing. And that means intubation becomes a team game. And we're going to talk more about that in the Operator 2 session. And finally, with a video laryngoscope, we can record the pictures and the videos that we obtain, which can then be used for governance and training. Now, all of that is super positive, but one of the biggest concerns of using video laryngoscopes in an emergency setting is the risk of contaminating the camera from blood or other fluids in the airway. And if that happens, you really can't see a thing. But with good technique, and Simon's going to run through that later on, you can really minimize that risk. Now, not only do you have to choose a laryngoscope, but you also have to select a blade too. And broadly speaking, there's two key groups, and that's either the curved blades, kind of generally known as the Macintosh, or straight blades, known as the Miller. And when it comes to adult intubations, we frequently use either a size 3 or a size 4 Macintosh blade. These have got a gentle curve on them, which helps us to slide over the tongue, a vertical flange, which assists us with displacing the tongue, and then a relatively wide tip with an obvious knob at the end of it. That's going to sit in the vallecula. If we're using a video laryngoscope though, we've got a third option, and that's a hyperangulated blade. Now, we're not going to cover these in detail here because they require a different technique for laryngoscopy, but it's worth knowing that they're around, and if you're using one, then you're probably going to want to set up a tube with a stylet inside it, because although getting the view is easier with a hyperangulated blade, it's much harder to pass the tube because the angles involved are much more pronounced. Some manufacturers will provide a rigid stylet which fits perfectly to the curvature of their specific blade. But if you haven't got access to that, then you're going to need to bend your flexible stylet to match the curve of your blade. And when you do, just make sure that the stylet isn't protruding out of the end of the tube. Now you might wonder why we don't use a stylet for every intubation. Well, this paper very nicely demonstrated to us that in a cohort of patients with a predicted difficult airway who were being intubated in the emergency department, first pass success was higher in the group where a bougie was used compared to the group in whom a styleted tube was used. But also of interest to us is that in patients with airway characteristics that we might encounter, such as cervical spine immobilization or airway contamination, there was also a significant improvement in first pass success in the bougie group. And as such, the humble bougie has pretty much become a standard of care for emergency intubations. But regardless of whether this is an RSI or a cardiac arrest, you're definitely going to want suction available, and ideally that's going to be a battery-operated one with a Yanker catheter attached. Now you're going to want the Yanker rather than a flexible one because the rigidity it gives you allows it to be directed more accurately, and its wider bore allows more rapid removal of fluid and particulate matter. And when you set up your Yanker, make sure you pop it on the right-hand side of the patient's head so that it can be easily passed to the intubator if it's required. And don't forget, if you do need to use it, then pop your thumb over that little hole near the top to close the circuit and generate the suction. That's definitely a bit of a gotcha in a high pressure situation. It's also worth mentioning the Ducanto catheter. This is an even wider bore catheter than the Yanker, and it's got a slightly more curved shape to better fit the oral cavity and the hypopharynx. That means you can get even more rapid removal of contaminants, and because it's got no hole to occlude it, it can be used for the salad technique. Okay. So, last few bits to consider. When it comes to tube sizes, in general, you're going to want a size 8 for an adult male and a 7 for an adult female, and you want to lay out the size you expect to use and the size below it, just in case the glottic opening is a bit smaller than you anticipate. We need to ensure that we tested the cuff on that tube and that it's lubricated to ease its passage through the vocal cords. And it's worth mentioning that cuff inflation should be done with a 10ml syringe because the optimal volume for cuff inflation probably lies somewhere around 6 to 7 mils. Now, carbon dioxide detection has absolutely become standard of care for intubation now, and the colorimetric devices give you a really rapid result to confirm tube placement. Just remember, yellow for yes, it's in the right place. However, waveform capnography gives you much more data that allows you to assess the efficacy of ventilation, the compliance of the lungs, the seal of your tube, and the physiology of your patient. So use a colorimetric device if you like, but it definitely needs to get changed pretty rapidly for waveform capnography. Worth noting though that sometimes there is a bit of a delay, isn't there, in monitoring after these devices are activated, so get them warmed up early on in that pre-intubation period. And finally, make sure you've got easy access to a supraglottic and your front of neck access kit, just in case things don't go quite to plan.
All right, James, well, you touched there on the idea of needing capnography to guide our longer-term ventilation and enable us to have a better insight of our patient's physiology. But what other elements of patient monitoring should we really be considering for that RSI?
Yeah, nice. And I guess primarily the answer here is that we shouldn't be taking any shortcuts at all. Because when we look at the guidelines on pre-hospital anaesthesia and the best practice documents on the topic, they're all aligned with the idea of matching the monitoring standards that we would expect in elective anaesthesia to the pre-hospital or the ED environment. Now, clearly there's going to be some items of equipment that aren't available to us and probably not that useful, like nerve stimulators and stuff. But as a minimum, the recommendations are that we should be monitoring non-invasive blood pressure, and that's going to be set to cycle every 2 to 3 minutes, pulse oximetry, continuous waveform capnography, ECG and heart rate, and continuous temperature monitoring. Now, that's the minimum standards expected, but for the right patients, you might want to add in things like invasive blood pressure or point of care blood gases. And I guess the key thing with all of this is that the full monitoring should be applied to the patient prior to the induction of anaesthesia, so we can really make sure we're optimising the patient before the induction and then keeping them safe both during and after.
And another really important bit, I guess, not just with the kit, is team prep, isn't it?
Yeah, absolutely. And that totally leads on with the idea of making sure that we're safe and efficient when it comes to our advanced airway management. I guess something I really like to use for this team prep idea is a short time out. Now, clearly that needs to be well timed. You don't want to be interrupting everyone in the middle of a safety critical intervention. But I think it's really valuable to draw everyone together to ensure that you all share the same mental model. Now, I guess if this is a cardiac arrest, then the team huddle might only be between operator 1 and operator 2. But if it's an RSI, then I think it's really important that it includes all members of the team, particularly if it's been a really busy job, and everyone has been off doing their own little individual elements of care. And I guess, what do we need to discuss? Well, I think we need to explicitly state that we're about to undertake an intubation or an anaesthetic, and within that, we need to include the indication for the procedure, because that then allows us to be challenged on our plan. And I think it's absolutely vital that we clearly outline the airway plan we're going to follow, and that includes specific items of kit, such as the type of laryngoscope, the size of the laryngoscope blade, and the size of tube that we're going to use. And if this is an RSI, then we need to talk through the drugs we're going to use and the dosages. And we need to make the team aware of the importance of being quiet, both during our checklist and the anaesthetic process.